Do you hear me? It's okay? Okay. So, no? Yeah, it's okay. So, hello everybody. Buenos dias. Agor. It's the only word I know in Basque. So, thank you Guillermo and Estivalis for the kind invitation to present you today some slides about autoantibodies in inflammatory myositis, and I will show you that those antibodies are quite precious help for clinicians, but for us members of the laboratory, it's not so easy to detect. So as you all know, idiopathic inflammatory myopathies are a rare group of acquired myopathies of autoimmune origin, and they are characterized by muscle inflammation and motor weakness, but which can rank from low weakness to very severe forms. They're also associated with extramuscular manifestations, such as pulmonary, as already described by Christina, but also cutaneous and arthritis. So those pathology represent a diagnostic and therapeutic challenge in different disciplines, including neurology, internal medicine, rheumatology, and of course dermatology. So a little bit of history about idiopathic inflammatory myositis. Initially, two main entities were described that were the dermatomyositis and polymyositis, and the diagnosis was mainly based on the clinical and anatomopathological feature. Then subgroups, new subgroups were refined that were inclusion body myositis and immune-mediated necrotizing form of myopathy. Still, there are overlapping syndromes that exist, such as antisynthetase syndrome, being classified as both dermatomyositis and polymyositis. So, the characterization of myositis-specific antibodies or myositis-associated autoantibodies was a major breakthrough in inflammatory myopathies diagnosis, but also classification. In fact, MSE or MAE are present in approximately 80% of inflammatory myositis patients. Myositis-associated and more specifically myositis-specific autoantibody help define subgroups of patients in terms of clinical or pathological phenotypes, such as ILD as example, but also organ involvements, cancer association, which is very important, prognosis also, and response to treatment. So the aims of this talk will be to present and to illustrate the significance of these markers, but also what is available in our routine lab for testing those antibodies and the pitfalls in the detection and the potential limitation of the tests. So be careful when you have a positive test in this kind of pathology. So myositis-specific autoantibodies were quite a cornerstone in inflammatory myopathy classification in a way, because as you can see here in this graph, you can segregate the pathology with antibody. Here are the dermatomyositis group with those antibodies. And this is the overlap myositis with antisynthetase syndrome here represented by the antisynthetase antibodies. But you also have the group of immune-mediated necrotizing myopathies with two main autoantibodies. And then the inclusion body myositis with specific antibodies, but also quite a lot of form with seronegative antibodies, because we don't know maybe the real target of the antibodies. Of interest, the most, if not all, antibodies that are described here are directed against ubiquitously expressed intracellular proteins that are muscle and specific, but they are associated to myositis. So let's have a look on the antisynthetase syndrome, which is mainly associated with interstitial lung disease, but also arthritis, cutaneous involvement, and most of all have weak myositis. So what are synthetase, T-RNA synthetase, the target of the antibody. Those proteins are enzymes that couple amino acids to the cognate transport RNA here for protein translation. And when we talk about Jo1 is this kind of enzyme that will transport histidine to the cognate tRNA synthesis, tRNA here, that will then go to the ribosome. That is Jo1. And here is the family of the autoantibody that's been described in the antisynthetase syndromes. The Jo1, as I said, is the most prevalent, as you can see here, associated with the prototypic antisynthetase syndrome. But as you can see, there are also other autoantibodies, and as said by Christina, PL12 and PL7 are very interesting autoantibodies to detect because they are clearly associated with a more severe form of interstitial lung disease. Among all those antibodies, those ones are detectable by commercially available tests, but but the last ones that are HR and ZOO are not detectable to date with commercial kits. No. Yeah. Let's have a, okay, great. So those antibodies can help defining subgroups in the antisynthetase syndrome. So let's have a look on the other form of inflammatory myositis and the help that can be brought by the autoantibodies. Here are the necrotizing form of myopathies with anti-SRP and anti-HMG-CR autoantibodies, and as you can see here, anti-HMG-CR antibodies are firstly described in patients that were statin users, but we know now that some patients who don't take statins can develop this kind of autoantibodies and the myopathy, the severe myopathies. Of interest, here are autoantibodies that are associated with dermatomyopathies, dermatomyositis, and two of them are very important because they are associated with cancer, strongly associated with cancer in the adult population that are the anti-NXP2 autoantibody, but also the type 1 gamma autoantibody that are form of dermatomyositis, strongly associated with cancer in adult patients. Of interest, some of the autoantibodies, if you detect these antibodies, most of the time those autoantibodies are associated with mild form of dermatomyositis that respond well to corticosteroids. So you have an association between the autoantibodies and the classification and the prognosis of your patient. Of all these antibodies, all are detectable with commercially available tests, except for this one, which is associated with the specific form of enclosure body myositis, but maybe somehow we'll have this kind of test in the near future. Recently, in 2015, new autoantibodies in severe inflammatory myopathy have been described. The anti-FHL1 autoantibody, as you can see here in this population of inflammatory myositis patients, near a quarter of those patients presented this autoantibody, and the target is a muscle-specific target. It's a protein that is expressed in the muscle, on the contrary of all the other antibodies that have been described so far. And mutation in these genes were associated with rare X-linked myopathy. So the author detected autoantibody directed against this protein in a quarter of the patient with inflammatory myositis, and it was associated, the presence of the antibody was associated with muscle atrophy, dysphagia, pronounced moist fiber damage, and also vasculitis. Maybe it's an antibody that's present in more severe form of dermatomyositis. However, to my knowledge, since this year, no match in PubMed for those antibodies in inflammatory myopathies have been published. And there is no commercial kits for detection to date. So I don't know if it's really specific, because no other group have described this kind of autoantibody. And last but not least, the myositis-associated antibodies, as I say, it's not specific for myopathy, but they are associated with myopathy, and they are associated mainly with lupus, scleroderma, or Sjögren's syndrome, as you can see, but they can be found also in inflammatory myopathies. So, here are my job. So I come in and enter the lab and see how we detect those antibodies in the routine practice. So, just this slide. Of what to be aware when testing autoantibodies for diagnosis purpose, general consideration, please be careful, because some treatment, as you know, will influence the results of the detection of the antibody in the laboratory. Those treatments includes administration of strong immunosuppressive drugs like high-dose corticosteroids, B-cell depleting therapies, for example. The administration of intravenous immunoglobulins, when you order a test after an administration of intravenous immunoglobulins, we can't do the test because maybe it would be negative, but it might be a false negative test. Of course, plasmapheresis can impact the results of the test. So all those treatments induce a risk of false negative results, of low positive results that can be difficult to interpret. So if possible, tests for diagnosis purpose should be performed whenever possible, of course, before any treatment that might affect the antibody detection. So, which methods can be used for the detection of autoantibodies in inflammatory myopathy? The first, the gold standard, if I can say, for detection of those antibodies, that's the way they were firstly described, is the immunoprecipitation and Western blotting using radiolabeled protein. So radiolabeled, it's not useful. It's not used in a routine lab. It's not an easy to handle technique. So it's not used in the routine lab, of course. But it was the first, the technique that was used for the first characterization of these antibodies. So it's a way to isolate a specific protein, here autoantibodies, from a complex mixture using immunoprecipitation and Western blotting. So it was the gold standard. It used native antigens, so it can be interesting for detecting a large scale of autoantibody, but it's time consuming and it's not a routine lab procedure, so it's difficult to use it in our labs. So it's not useful. So what about the indirect immunofluorescence on HEP2 cells? You all know this technique that is used for detection of anti-nuclear antibodies, for the detection and the diagnosis of patients with connective tissue disease. So we use serum from the patient, and you use those slides that are on which are plated human cells, the HEP2 cells, and then using an epifluorescent microscope or automatic analysis of the image, as you can see here, we can detect some specific patterns that are associated with autoantibodies. And for example, here are the examples from the laboratory of Bordeaux, where we work, Patrick and I. Here is an homogeneous staining of the nucleus of the cell. Here are the cells, here are the nucleus, and you see this homogeneous green signal. That it means that the patient have autoantibodies directed against the nucleus, and it is reminiscent of anti-double-strand DNA, nucleosome, or histone autoantibody that will be further detected using other technique. Here is a coarse speckle pattern of the HEP2 cells with granulation in the nucleus, and they are reminiscent of anti-RNP or anti-SM, for example, antibodies. And here is the anti-centromere pathognomonic pattern of the HEP2 cells with numerous dots in the nucleus that is associated with anti-centromere B antibody that is found in scleroderma. So the question was, okay, if this kind of technique could be used for the detection of cytoplasmic, of MSC or MAE in general. And when you perform when you request an AD detection on EP2 cells, you can see, okay, nuclear staining, but you can also detect a lot of other kind of patterns, and one of those patterns can be cytoplasmic patterns. And if you want to go further on the detection of the antibody, please refer to this site, which is really nice. So here is what we can see in your patient when you order an AD testing. We can detect a lot of other things, and we can detect cytoplasmic staining. Here are, you see here in black, it is the nucleus. It's not stained, the nucleus is negative, but around the nucleus you get a strong cytoplasmic staining. It's fine speckled and around the nucleus. Here it's an anti-PL7 autoantibodies that give rise to this kind of fluorescence pattern. Here an anti-PL12, you can see it's quite similar. You can't make the difference, but when you have this kind of pattern under your microscope, you must be aware that some of those antibodies can be hidden in this pattern. Here is an anti-SRP autoantibody staining, and it looks like PL7 and PL12. Anti-JOY1 have different pattern, so when you are expert in immunofluorescence, you can tell, okay, it looks like the JOY1, and you must be aware also of this kind of cytoplasmic pattern, because it can be associated to this kind of autoantibodies. So here are the cytoplasmic staining, and also nuclear staining can bring some information concerning the potential presence of MSE or MAE autoantibody. Here is the PM-SCL staining. I'm sorry, it's not very easy to see, but you have here the nucleus, and inside the nucleus you get the nucleosomes, the nucleoli, yes, in English, the nucleoli, and the nucleoli stain positive, brightly positive inside the nucleus, and is associated with this kind of pattern, is associated with anti-PM-SCL autoantibody. It was in a patient presenting scleromyositis. We can also detect some fluorescent data reminiscent of anti-MI2 autoantibody, but it's very difficult to detect. So it's more or less associated with labs that are competent, very competent in immunofluorescence. It's quite difficult to detect, but we do so in the lab. So anti-MI2 or here the anti-KU, which is a myositis-associated autoantibody. So EP2 cells can help the detection of those antibodies, but you need to know that up to 14% of genuine anti-synthetase autoantibody, that is JOY1, PL7, PL2, 12, etc., are not detected on EP2 cells because of a lack of sensitivity of this test. So that's the first problem. The second problem is that some MSE have no specific staining because they gave rise to nuclear speckled staining, and it's true for type 1 gamma, SI1, or NXP2. So it looks like many other autoantibodies. So it's not specific. The patterns are not specific. So no help is brought from EP2 cells in this case. So how we detect the autoantibodies, or cytoplasmic staining, if you want to see. Oh, sorry. So it's exactly what I say. Be careful on EP2 cytoplasmic staining. On the first hand, you must be careful when you have a report from a lab that notice that there is a cytoplasmic staining on EP2 cells. You need to be aware that it could be of interest to pursue the analysis. For example, if you have an idiopathic interstitial lung disease patient and a cytoplasmic staining that is specific, like I showed you before, you must be aware of this cytoplasmic staining and discuss with the lab to perform new analysis if the clinical status is in favor. But on the other hand, labs should be mentioned cytoplasmic EP2 staining that might be related to useful antibodies. If they do not, you don't have the information. So it's really important that the labs you are working with are able to detect those kind of cytoplasmic staining. So those Ep2 cells are great because they detect a large spectrum of autoantibodies, but they are low sensitive, and thus they can't be the only screening tools for myositis antibody detection, and this needs a lab expertise in order to interpret the pattern of Ep2 cells. So in the lab, most of the lab use immunoblotting for the detection of autoantibodies, of MSC and MAE autoantibodies. What is immunoblotting? Immunoblotting is this membrane in which you have specific autoantigen that are spotting on it. Here GI1, here PL7, PL12, etc. Then you put the serum of the patient on this membrane, and if there is autoantibody specific toward the antigens that are spotted on the membrane, then they will fix, and then we will reveal these autoantibodies using a secondary antibodies that is coupled with an enzyme. And if the second antibodies contact the first antibodies that were contained in the serum, we will detect a signal, and this is this kind of signal, a colored signal that will rise. And this signal, this spot, means that your patient have autoantibodies directed against JAW1 in the serum. But in this case, it's a patient from the lab. You have also anti-SSC52 and TRO antibodies. The second patient presented with a dermatomyositis, and as you can see here, he was positive for anti-SIA1 and weak positive for SIA2. So that's in the everyday practice. But this technique have strong it's great because it's rapid, it's multiparametric, it's easy to handle, that's great. But there is many pitfalls and issues with those techniques. Here is an example. Here is the UK NICRAS survey for laboratory. More than 150 laboratories around Europe receive a serum sample. All the laboratory have the same serum samples. And we need to tell the NICRAS, okay, I found, I don't know, anti-JAW1 or anti-PL12 antibodies in this serum. And this is the result of the survey. As you can see here, for PL12 antibody, more than the half of the responders say, okay, there are some anti-PL12 antibodies in the serum, but the other half said, no, there isn't. So who is wrong, who is right? This serum came from an anti-SL17 positive patient with scleroderma without any myositis. So, and what is interesting, all the positive returns used, the laboratory that stated positive anti-PL12 antibodies used the same manufacturer to detect these antibodies. So maybe there is a bias or something wrong with this manufacturer. We don't know. Here is our experience with Pierre here. We perform a retrospective analysis of the results we obtained with this kind of technique, with those dots on patients. And as you can see here, in this 3 years period, we detected 13 type 1 gamma positive patients. Within this positive patient, only 7 were genuine dermatomyositis. 27 were non-immune-mediated myopathies. And when we look at the signal we can detect on the membranes, we found 8 borderline positive signal. Like you can see here, is the negative control, is the signal we have here. So it's borderline positive. We don't know if it's true or not true. But you see something, so it's difficult to say, no, it's bullshit. I don't want to report it on my analysis. And here we also have 15 strong positive patients for anti-type 1 gamma, but no myositis. Same for anti-SI1 and XP2, as you can see here, only 3 dermatomyositis, 1 dermatomyositis that were positive, and the other were non-inflammatory myopathies, and some have strong signal. And among those patients, we found SLE, Sjogren's syndrome, scleroderma, a lot of scleroderma, I must say, RA, and cryoglobulinemia. So what is that? Is it cross-reactive antibody? Is it specific antibodies? Would this patient develop a myopathies in the near future? We don't know. And we are not the only lab to say that, because here in this French group also described the same results in 2018. And what they say, what they show is that among the 68 positive patients that they had in their lab for MSC antibodies, only half of the patients have real inflammatory myopathies, and the other had connective tissue disease or other diagnostics such as inflammatory disease, such as infection, or so on, and cancer, and so on. So it's really difficult to get the good likelihood ratio for those antibodies. That means likelihood ratio is the way to analyze the performance of the test is that you find the antibody in the patient that suffer from the disease, but you don't find the antibody in patients who don't suffer from the disease. So the likelihood ratio is quite poor using when you detect autoantibody directed against specific myocytic antibodies. And they also make a point on the signal we detect. So if you only focus on strong positive antibody detections, at the strong signal that I've shown you before, the likelihood ratio increased drastically, as you can see here. So weak signal seems to be non-specific, but maybe the patient had corticosteroids, that's why the level of antibody dropped down and can allow the detection of weak positive signals. So it's not so easy to say, okay, it's only the real positive are interesting and the lower ones are not interesting for diagnosis. That's not true. And in order to complexify a little bit, I'm sorry for that, but that's the real life of the laboratory, and you need to be aware of that when you interpret the results of a laboratory. There is strong difference in the manufacturers in the performance of the test. Here, 3 manufacturers for detection of MSC antibodies, and we can only see the likelihood ratio here. When you see the likelihood ratio, you see strong discrepancy between manufacturers. For Joe1, for example, this test is very, very accurate from AlphaDia, but those 2 other tests are not accurate because the likelihood ratios are really poor comparing with this one. Because those tests detect a lot of positive patients that have no myositis at the time of the diagnosis. Of interest here, when you compare these 3 same manufacturers, you can see here that this manufacturer have low sensitivity for anti-type 1 gamma antibodies compared to the other manufacturer. So if you use this antibody, which works well for the other MSC, it's quite a good test for other MSC, be aware if you have a strong clinical suspicion of dermatomyositis and maybe cancer-associated one, and you have negative result for type 1 gamma, you should test with another manufacturer in order to be sure that the antibody is negative. So it's difficult, but laboratory must be aware of that and must be able to communicate with the lab and with the clinician in order to discuss the best option to choose for detection of the antibodies. So, if I resume, there is a lack of standardization among manufacturers, as I shown you before, heterogeneity in performances, and so poor likelihood ratio that depends on tests you use and the autoantibody you want to detect. So it raises a lot of questions that I've already mentioned. So we need to improve, the manufacturer need to improve their test and to standardize their test in order to perform better. So, of course, it's really important to associate clinical data up to staining that can help immunodots and the dialogue between clinician and biologists to improve the accuracy of autoantibody detection in inflammatory myositis. Thank you very much for your attention.